cover this topics of pre-operative. This video is purely purpose for the study, no any professional or any other activity. It is for the study purpose. So pre-operative care of the patient for preparation for MRCS. There are different books, different topics are from the different books. So see, this topic is very wonderfully expressed in this, and in a short it is 10 pages pre-operative. The first thing is ASC grading. American Society of Anesthetists grading pre-operative preparation. When the patient is taken for, there are 5 grades: ASC grade 1, 2, 3, 4, 5. Grade 1 is no any abnormality, no any pathology in the person, perfectly fit, and whatever surgery you are going to do is localized. Example is excision of lipoma, or you do inguinal hernia surgery. So it doesn't invoke any systemic disturbance. It is grade 1. Grade 2 is there may be mild systemic disruption like diabetes, hypertension or something, but which is controlled. Grade 3 is severe systemic disruption either by surgical pathology or pre-existing disease which is not yet controlled. So uncontrolled diabetes, uncontrolled hypertension, that is in the grade 3 and has got a grade 4 is there is constant threat to the life. So this is grade 4. Patient who is moribund. Fifth is moribund, he cannot survive without surgery. That's why patient is taken under grade 4. That is most of the time called as stable death consent. So this is preparation of the surgery, elective and emergency patients. These are two different, emergency and elective. Elective cases means where you can postpone, decide, plan everything. You have got time. There is no emergency. So pre-admission clinics has to be done. Blood testing is most commonly done. Full blood count, urine examination, liver function test, clotting and everything. Pregnancy test, sickle cell test, all these tests are done. So exact tests to be performed will depend upon the proposed procedure and fitness. So most of the time it is called as pre-anesthesia checkup, PAC or fitness. Risk factors for development of deep vein thrombosis should be assessed and planned for thromboprophylaxis. You have got the time to plan for thromboprophylaxis. So diabetic patients which we are taking for elective cases, what you do, they have got greater risk of complications. So poorly controlled diabetes has got risk of wound infection. Patients with diet or tablet controlled diabetes may be managed using policy of omitting medication and checking blood glucose regularly. So this oral tablets, type 2 diabetes mellitus who are dependent on the tablets, that should be omitted on the day of surgery and regular checking is done. Who are poorly controlled and who take insulin may require intravenous sliding scale and potassium supplementation should be given. So emergency cases, here this is an emergency. You don't have much time to decide whether patient is having associated pathology and there is no time to serve. So stabilize and resuscitate the patient. Consider antibiotics needed and when and how should be administered. Inform blood bank for the major coagulopathies and all that. Don't forget to consider inform relatives. Special preparations are, some procedures require special preparation. For example, thyroid surgery, you need a vocal cord check. Parathyroid surgery, you do sometimes methylene blue to identify the glands. Here methylene blue is used. For sentinel node biopsy, radioactive marker or patent blue is used. Surgery involving thoracic duct, here you use cream. Orally cream is given 2 hours before so that it fills the thoracic duct. When a thoracic surgery or esophageal surgery is done and near the thoracic duct, the leakage can be detected immediately. Pheochromocytoma need blockage by alpha and beta blocker. Surgery of the carcinoid tumors need covering with octatroid. So this is octatroid. Colorectal cases, bowel preparation is generally avoided. Only on the left side of surgery, so you have to just evacuate. Thyrotoxicosis, Lugol's iodine, and medical therapy. So these were about the drugs. So pre-operative fluid management, how to do. Fluid management has described British consensus guidelines on IV fluid therapy, adult surgical patients. So gifts up and nice guidelines, December 2013. Recommendations say the use of ringer lactate, RL or a Hartmann's, when crystallized is needed for resuscitation purpose. Avoid normal saline because it causes hyperchloremia, hyperchloremic acidosis unless patient is vomiting and gastric drainage is there. So this is another second thing is 4% 1.18 dextrose with or 5% dextrose maintenance. It should not be used in resuscitation as replacement fluid. Adult maintenance fluid requirements, they are around sodium around 50 to 100 millimoles and potassium 40 to 80. So this is for the adult ideal age patient of 70 kg, just equivalent to 1 milliequivalent per kg per day, and this is 2 milliequivalent and 1.5 to 2.5 liter fluids. Patient for elective surgery should not be nil by mouth for more than 2 hours, and a carbohydrate rich drink has to be given before to get enhanced recovery. This is a part of enhanced recovery. Avoid mechanical bowel preparation. If bowel preparation used, simultaneous administration of heart ringer should be considered because bowel preparation causes loss of much of the potassium. Excessive fluid losses from vomiting should be treated with crystalloids, and potassium replacement is needed. 0.9 normal saline should be given if hyperchloremia, otherwise heart ringer lactate used for diarrhea and all that. High-risk patients should be receive fluids and inotropes. An attempt should be made to detect preoperative hypovolemia using flow-based measurements. So hypovolemia, if this is not available, the clinical evaluation needed. JVP and pulse volumes are read. In blood loss or infection causing hypovolemia should be treated with balanced crystalloid cholesterol unless blood is available. A critically ill patient is unable to excrete sodium or water, leading to 5% risk of blood 5% risk of blood interstitial edema. Therefore, 5% dextrose should be as a colloid. So, what happens? A critically ill patient, therefore, 5% dextrose as well as colloid should be given. So, interstitial edema in this case, critically ill patient. If the patient needs IV fluid resuscitation, crystalloid and contains sodium in the range of 130 to 154 micrograms with bolus of 500 ml over 15 minutes period has to be given. Intraoperative, this is preoperative. Now, intraoperative, what is you are giving? Sodium, potassium, chloride, bicarbonate, lactate. These are the important sodium and potassium. Sodium has to be given. Normal saline contains 153, and Ringer Hartmann solution contains it is exactly what is there in the plasma. 137 to 147 is sodium content. So Ringer lactate contains 130. Potassium is 4 to 5.5. So potassium is 4. And chloride is 95 to 105, so chloride is 110, and it additionally it contains lactate of 28. So Ringer lactate or a Hartmann solution is used. Recommendation for intraoperative fluid management. So a special address is required intraoperative. The reason for this is that administration of the fluids in a specific section does not lend itself to rigid algorithms. With the introduction of enhanced recovery program 10 years ago, there was an increasing emphasis of concept of fluid restriction. Historically, patients received large volumes of saline-rich solutions perioperatively. Clearing the sodium load of single liter of saline may take 36 hours. This can have a deleterious effect on the tissues, including development of edema. This results in poor perfusion, increasing risk of ES and bone breakdown. A tailored approach to fluid administration is now practiced, and far greater usage is maintained by cardiac output monitors. So, what are the intravenous accesses? Different. So, number of venous accesses, peripheral venous cannula, easy to insert. Even wide lumen cannulae can be used. Rapid infusion, properly managed infections may be managed. Problems related to peripheral sites are unsuitable administration of vasoactive drugs such as inotropes and irritant drugs such as total parenteral nutrition, and also potassium is irritant, so it's difficult. Central line is more difficult, more operative nice use of ultrasound guided detection of the veins, and coagulopathy may lead to hemorrhage following iatrogenic arterial injury. Central line, particularly subclavian lines. Subclavian lines are risk of development of pneumothorax, so you have to be very careful. Femoral lines are easier to insert and iatrogenic injury easier to manage in the site. However, are prone to high infection rates. Internal jugular is preferred. Internal jugular is preferred. They have multiple lumen, allowing for administration of multiple infusions. The lumens are relatively narrow and thus do not allow particularly rapid infusion. So, other is intraosseous. This typically enteromedial aspect of the proximal tibia. Access to marrow cavity in circulatory system, tradition preferred for pediatric patients where you are difficult to getting the IV cannula. So tunnel lines, what is this? This is Grosshang and Hickman. These are the tunnel lines and popular devices for the patients with long-term therapeutic requirement. Devices usually inserted under USG guided internal jugular vein and then tunneled under the skin and cuff of the wound material is sited near the end tapes to the anchor the device in the tissue. The cuffs require formal dissection to allow the device to be removed. Tunnel lines are linked to the injection ports and they are located under the skin. They are especially popular in pediatric patients. Peripheral inserted cannula, referred to as these are the PIC lines. They are popular method for establishing central venous line because they are inserted peripherally and less prone to major complications. This was about the lines which are put inside the body for giving intravenous infusions. So, which is a common drug? Atropine is a muscarinic. It is a muscarinic receptor antagonist, competitive antagonist for muscarinic acetylcholine. It is therefore inhibits the parasympathetic activity. It was traditionally used as a pre-medication for anesthesia. It was medication because it reduces bronchial secretions. Basically, secretions are reduced, salivary secretions are reduced, bradycardia from increased vagal tone is also reduced. So this is traditionally used as a anesthetic medication. Modern techniques have reduced the need of routine use of drug. Its other effects include urinary retention, peptidation. Local anesthesia agents, these are lignocaine, xylocaine. Lignocaine commonly used as antiarrhythmic drug. Effects by blocking the sodium channels. Hepatic metabolism, protein bound toxicity, IVA. Drug interactions, beta blockers, ciprofloxacin, phenotine. Toxicity is initially CNS over depression and lignocaine blocks the inhibitory pathways and the blocks the inhibitory and activating pathway. Cardiac arrhythmias may occur. The increased doses may use when combined with adrenaline. So if it is combined with adrenaline, doses may be increased and to limit systemic absorption. So adrenaline causes vasoconstriction, so systemically it is less absorbed. That's why it is useful. Cocaine, pure cocaine is salt and cocaine hydrochloride local anesthetic purpose. As a paste, is applied to clinical concentration of 4-10%, topically applied to nasal mucosa and rapid onset of action, additional marked vasoconstriction, lipophilic cross the blood-brain barrier. Bupivacaine is binds intracellular portion of sodium channels and blocks the sodium influx into the nerve cell, prevents depolarization. It has much longer duration of action than lignocaine and is of use in. It may be used for topical wound infiltration, including surgical procedure with long duration anesthesia. Cardiotoxic and therefore contraindicated the regional blockage in the tourniquet fails. Prilocaine mechanism of action to local anesthetics. However, it is far less cardiotoxic, so is therefore used for agent of size intravenous regional base block are used. All local anesthetic agents dissociate in the tissue and therefore therapeutic effect and dissociation constant shift. So the toxic dose is 3 mg per kg for plain lignocaine and 7 mg per kg with adrenaline, and bupivacaine is 2 and 2 mg per kg. Prilocaine is 6 and there is guide only. Actual doses depend on site of administration. Doses actually depends on site of administration, tissue vascularity and comorbidities. So maximum doses can be used is lignocaine 1%, it is 3 mg per kg. So this is ideal body weight. It is supposed to be for 70 kg person. If person is of 70 kg, it will be 3 into 70 divided by 10, that is around 21 ml. So 20 ml is the maximum dose which can be given. That's why it is called as 20 ml in 70 kg. A person is of suppose 100 kg, so it will be higher dose can be tolerated. If the person with lignocaine it is, then if you go with the 7 mg per kg with adrenaline, it is around up to 70 kg person is there. So again 490, so divided by 10, so 49 ml, so around 50 ml is with. So bottle is of 40. Then bupivacaine, again it is ideal body weight is 70 kg. It can be given 2 mg per kg. So it is 150 into 2 divided by 0.5, 300. So it's around 30 ml can be. That is the calculated in this manner. So effect of adrenaline may be added to the local. Adrenaline prolongs the duration of action site and permits the use of higher doses. It contrasting the patient with MAO inhibitors, tricyclic antidepressant. The toxicity is related to protein bound additional to this. So what are the anesthetic agents? These are propofol, sodium thiopentonate, ketamine, etomide. So rapid onset of anesthesia and IV it can be given. Metabolize accumulation, metabolic antiemetic properties are good. So So widely used, especially mediating sedation or ITO and total IV anesthesia for day case surgery. Thiopentone, extremely rapid action, its agent for choice, or rapid sequence induction, mark microdiffusion and metabolism quickly and unsuitable for maintenance infusion. Ketamine may be used for induction of anesthesia as moderate to strong anesthesia, may produce little microarterial depletion, make it suitable for anesthesia in those who are hemodynamically unstable. Favorable cardiac side effects is instability, no analgesia properties, unsuitable for maintaining sedation as prolonged, may be used in adrenal suppression, may result in adrenal suppression. Post-operative vomiting is common. So how is this airway is managed? You use, these are the important airway management. Oropharyngeal airway, it is easy to insert, no paralysis required. You can directly put, this is oropharyngeal airway, this is oropharyngeal, just to maintain this, and this one is laryngeal mask, and this is endotracheal tube. So oropharyngeal airway, no paralysis required, ideal for short procedures to maintain the ventilation. Widely used laryngeal mask, very easy to insert, device sits on the pharynx aligned to cover the airway, poor control against the reflux gastric contents, paralysis not required, commonly used for wide range of anesthesia drugs, especially in day case surgery, not common for the high pressure ventilation. Endotracheal tube provides optimum control of airway which has cuffed inflation, may be used for long-term ventilation. Errors in air insertion may result in esophageal intubation. Therefore, tidal CO2 is measured and paralysis often required. High ventilation. Tracheostomy reduces the work of breathing. It reduces dead space and may often use in slow weaning. A person is on a ventilator and weaning has to be done, so you put tracheostomy. Percutaneous tracheostomy while used and dries the secretion. Muscle relaxants before putting an intubation or that due to depolarizing and non-depolarizing. Depolarizing muscle relaxant succinylcholine inhibits the action of acetylcholine, a neurotransmitter degraded by plasma cholesterol, affected by lack of fast onset and short duration of action. All muscle relaxants produces generalized contractions prior to adverse side effect of hyperkalemia, malignant hyperthermia, and delayed recovery. Atracuronium, vicuronium, pancuronium, these are non-depolarizing. Duration of action is 30. Atracuronium is 30 to 45 minutes. Not excreted in kidneys, liver, hydrolysis, reversed by the neostigmine. These are reversed by neostigmine. So this is reversed by neostigmine. This is reversed by neostigmine. This is reversed by dantrolene. Dantrolene. So malignant hyperthermia, condition which administration of the anesthetic drug, conditions seen following administration of anesthetic agents. So characterized by hyperparaxia and muscle rigidity. There is muscle rigidity caused by excessive release of calcium from the sarcoplasmic reticulum of the scrotum. Associated defects in gene on chromosome 19 encoding the rhabdomyosin, which controls calcium release from neuroleptic malignant syndrome may similar to the etiology. Causative agents are halothane, succinylcholine, other drugs, antipsychotic may lead to malignant hyperthermia. So CK raise contracture test contraction with halothane and caffeine. Dantrolene has to be used whenever there is malignant hyperthermia, prevents calcium release from. Tonic acid is used during surgery to minimize the blood loss and ensure clear operative field. Must be correctly applied and monitored. Applied to the extremity, and most common cases are inflicted using pressure monitoring system. The number of systemic they are divided into those which occur following inflation and those that occur once tourniquet is deflated. Post-inflation, increased systemic vascular resistance increases CVP and increased blood pressure, slower gradual increase in blood pressure over the time, slower hypoglycemic state, and post-deflation fall in CVP, blood pressure, and SVR, enhanced fibrinolysis, fall in core temperature. Contraindications is AV fistula, severe peripheral vascular disease, peripheral vascular surgery, and bone fractures. In all these, it is contraindicated. Sickle disease, all this can be a local complication, damage to skin, muscle damage, compartment syndrome, damage to vessel, neuropraxia. So what are the blood products and cross-matching? Packed cells used for transfusion in the chronic anemia and cases where infusion of the large volume of fluids may be result in cardiovascular. So these are the products obtained by configuration of the packed cells. Platelets usually measure thrombocytopenia and they can be used. Prepared by high-speed centrifugation are the platelet concentrated and fresh flow plasma. Single unit of the blood contains clotting factors. Unit is usually 200 to 250 ml. Usually used in correcting clotting factors in the patients with hepatic synthetic failures. Usual dose is 12 to 15 ml per kg. It should not be used as a first line of therapy for hypovolemia. Cryoprecipitate formed from the supernatant the sag mannitol. This must be cross matched. What is back cells must be cross matched, whole back must be cross matched, can be ABO incompatible, platelets can be there. Prophylaxis in surgical patient. What you do, deep vein thrombosis may develop in surgical patient. Untreated must be used. The following surgical patients are risk for developing DVT. Surgery which is lasting more than 90 minutes at any site or 60 minutes at the lower extremity. Acute admission with inflammatory process, abdominal cavity. Expectant reduction in mobility. Age more than 60 years. Known malignancy. Thrombophilia, previous thrombosis, BMI is more than 30, taking hormone replacement surgery, quota contraceptive pills, varicose veins, phlebitis. Mechanical thrombophlebitis, early ambulation after surgery is cheap and effective method. Compressed stocking, contracting peripheral vascular disease, intermittent pneumatic compression devices, foot impulse devices, therapeutic agents, low molecular weight heparin, unfractionated heparin, and dabigatran. So low molecular heparin binds with antithrombin, causing it is activating the antithrombin to cause inhibition of factor 10A. Thrombophlebitis or treatment of thrombin in those and unfractionated heparin binds with antithrombin 3, affecting thrombin and factor effective anticoagulation quickly and stopping the orally administered thrombin inhibitor. These are the dabigatran, antithrombin, platelet, prophylaxis in hip, any surgery, then proactive care of people undergoing surgery, POPs. Comprehensive geriatric assessment and multi-drug treatment assessment preoperatively. Main precursor of the complications are comorbid cardiac disease. Preoperative assessment is key to prevent adverse postoperative complications. Patients screen for risk factors, albumin less than 30 and comorbidities. Management plan should be this fewer postoperative vehicle complications. Reduce length of stay by 4.5 days.